Yes, sir. We are live now. We can start with the session.
Okay. So, am I visible, madam? My skin is visible, madam?
Just a moment. Yes, visible. You can make it into slideshow from bottom. Slideshow. Yes, slides are
Good
visible to
evening,
you,
madam.
doctor.
Is,
Okay.
is it visible, madam?
Doctor, the slides are visible to you?
Yes,
Okay, okay, ma'am. Yes, ma'am, you can, I guess your camera has been tilted, right?
yes.
Okay, okay. We can start. Over to you, sir. We can start.
Yes. Good evening, everyone. I am Nakibul Jamal on behalf of Glenmark Pharmaceutical. Welcome you to today's webinar on the topic cardiometabolic protection with GLP-1 RA. So it gives me immense pleasure to introduce our speaker for today, Dr. Arunayan. Uh, Dr. Arunayan is currently practicing as a consultant physician and diabetologist, bring a wealth of experience and expertise on our discussion. Now, without taking any more time, I request Dr. Arunayan to initiate today's webinar. Over to you, Doctor.
Good evening. Thank you for this opportunity and for the warm welcome to the Glenmark team. So, we are seeing that India is gaining the notorious capital of being the diabetes capital of the world. And along with this, we are having a lot of cardiac, renal, and other metabolic complications also being associated with uncontrolled blood sugars. We need to use a drug which controls not just the blood sugars, but also offers cardiometabolic protection. In that regards, let us see GLP-1 receptor agonists, which could offer a cardiometabolic protection, not just in diabetes, but also in pre-diabetics, people with obesity, and with other risk factors also associated. Next slide, please. Next slide. Next slide. So, in today's discussion, we would be seeing an overview of obesity and type 2 diabetes in the Indian population with the specialized interest into the CV risk in obesity and diabetes. And we will have two case discussions. There is a rising trend of overweight and obesity. This is related to the changing lifestyle and the dietary patterns. Over the years, in the past decade, if we see, the incidence of overweight as well as obesity has increased from about 25% to almost 40%. This puts the population not just at risk of type 2 diabetes, but also other cardiovascular disorders. Next slide, please. Although the international definition for obesity is a BMI of more than 30, we find that in the APAC population, that is the Asia Pacific population, even with a lower body weight, when compared with the other populations, they tend to have a higher amount of body fat, especially visceral adipose tissue. The APAC populations develop obesity related morbidities, including type 2 diabetes, dyslipidemia, and cardiovascular disease at a lower BMI than the international definition of obesity. Next slide, please. A lower BMI cutoff for obesity has been recommended for the APAC population to improve the identification of individuals at risk of cardiometabolic diseases. Many countries in the APAC region apply a BMI threshold of 25 or at the maximum of 27.5 to define obesity. A BMI of more than this is considered as to be obese. Most countries in the APAC region also apply a waist circumference threshold of more than 90 for men and more than 80 for women to define central obesity. However, cardiovascular disease risks associated with body mass index have been reported to increase at 21 itself. And nowadays, we are seeing that it is not just a BMI calculation, but also including a holistic measurement like the waist circumference, and a body fat measurement, where we can have an accurate idea of the visceral fat as well as the subcutaneous fat. All of these put together go into defining the person as obese or not. Next slide, please. So, the different parameters or indicators to define obesity in the Indian population are a waist circumference of more than 90 in males, of more than 80 in females, a waist hip ratio of more than zero point 0.9 in males and more than 0.85 in females, a waist circumference of more than 16.5 in males and 15.7 in females, and a neck circumference of more than 35.25 in males and more than 34.25 in females. One of the indicators which we're using more frequently nowadays is a body fat percentage. A cutoff of more than 25% for males or more than 30% for females is considered to be obese. And the body mass index is considered as more than 23 is overweight and more than 25 is obese. Next slide, please. In India, the prevalence of diabetes, prediabetes, and other metabolic risk factors such as obesity, dysglycemia, blood pressure, and physical inactivity is increasing. It has been noted that at least 10.1 crore people with diabetes will be there by 2021. And the prevalence of prediabetes is also increasing to 15.3%. Over 60% of individuals with prediabetes can transition to type 2 diabetes within 5 years if they are not managed. That brings us to what are the unmet needs in the management of type 2 diabetes. Next slide, please. We have the uncontrolled glycemic targets, associated overweight and obesity, type 2 diabetes associated with other comorbidities like cardiovascular diseases, high incidence of renal disorders, a high prevalence of liver disorders like MAFLD, and also addressing other metabolic concerns like PCOS and osteoarthritis. Next slide, please. So, can GLP-1 regulators be regularly used in cardiometabolic practice? The barriers in the decision making. Let us see into what they would be. Next slide, please. Overweight or obesity increase risk of CVD events even in the absence of metabolic abnormalities. We find that compared to a normal weight person, by the time they reach a level of obesity, coronary artery disease, cardiovascular disease, and heart failures sharply increase. Next slide, please. The 2023 guidelines for the management of cardiovascular diseases by the ESC in patients with diabetes states that if a person is having type 2 diabetes or cardiovascular disease or a chronic disease, a chronic renal disorder, which is confirmed, you need to start segregating those patients. You need to see whether they have established ASCVD or a heart failure. In that case, we need to reduce the cardiovascular risk independent of the glucose control, and also to reduce the heart failure hospitalization in all patients with type 2 diabetes and progression of the heart failure. We also need to consider to reduce the cardiovascular and renal failure risk. To reduce the cardiovascular event risk, or they reduce the risk of hospitalization for heart failure, GLP-1 receptor agonists, SGLT2 inhibitors are indicated. And to reduce the cardiovascular and renal failure risk, SGLT2 inhibitors and finerenone is indicated. Next slide, please. Let us have a clinical example with a legacy patient who has an increasing risk. Our case is named as Mr. Surender, age 66 years. He's a retired engineer who has a height of 173 centimeters and a body weight of 81. We find that his body mass index is 27, which is in the obese category. He has a medical history of type 2 diabetes for 12 years. He had a CABG about 5 years ago and also has stage 1 hypertension. He has slightly raised uncontrolled blood sugars at 7.2% of HbA1c. His EGFR is also slightly reduced at 84. He has a LDL value of 68 milligrams. Presently, he is on atorvastatin, aspirin, empagliflozin, and telmisartan. His 2D echo of shows that he has an ejection fraction of 55% and no diastolic dysfunction is noted. What are the ACC, AHA, EAC, and ADA summary guideline recommendations for the usage of GLP-1 receptor agonists? Next slide, please. Next slide. So, if you note over here, from 2019, when it was a class 2A recommendation, it has moved up to class 1 recommendation. And at present, it says that GLP-1 receptor agonist studies need to be performed before determining its efficacy in reducing MACE after acute coronary syndrome. And GLP-1 receptor agonists with proven cardiovascular benefit in patients with diabetes and chronic coronary disease can reduce the risk of MACE. Next slide, please. The cardiovascular benefits of GLP-1 receptor agonists are well documented in stable patients with ASCVD and type 2 diabetes, patients with heart failure regardless of the diabetes status. GLP-1 receptor agonists may lead to weight loss in many patients, and semaglutide has been shown to reduce the risk of MACE in overweight or obese patients with stable ASCVD but has not been studied early after ACS. Next slide, please. So, as per the 2024 ESC guidelines for the management of chronic coronary syndromes, SGLT2 inhibitors and all GLP-1 receptor agonists in patients with chronic coronary syndrome has been given a class 1 evidence. And in patients with overweight or obesity, to reduce the CV mortality, MI or stroke, it has been given a class 2A evidence. Next slide, please. When it comes to managing patients with obesity, the ASO 2025 guidelines says that obesity management, you need to see if the patient has just a body weight management or there is also any other complications associated with increased body weight. If no complications are present, the goal to treat would be fat mass accumulation to prevent dysfunction in non-adipose organs. In that case, the total body weight loss is the endpoint, and you could use tirzepatide, semaglutide, phentermine or for the topiramate combination, liraglutide, or a naltrexone bupropion combination, or orlistat. If there is any complication present, the goal to treat would be to reverse the dysfunction in the non-adipose organs. You need to see in the fat mass diseases as well as the sick fat diseases. In the fat mass diseases, there could be altered and pathological and also mechanical forces. These could be causing obstructive sleep apnea or knee osteoarthritis. By using drugs like tirzepatide, semaglutide, we can find remission of both of these. When you come to sick fat diseases, you need to consider deranged endocrine and immune responses also. This could be either in diabetes or non-diabetics or pre-diabetic. Non-diabetes would include in CVDs, heart failure, or MASLD. Pre-diabetics with normal glycemia restoration, tirzepatide, semaglutide, liraglutide, and orlistat is recommended. In type 2 diabetics, tirzepatide, semaglutide, liraglutide, naltrexone, and bupropion combinations are approved. When it comes to management of sick fat diseases in CVD patients who have had MACE, to reduce the further events, semaglutide and naltrexone bupropion combination is approved. And to reduce the risk of hospitalization for heart failure, tirzepatide or semaglutide is approved. And when it comes to reducing or remission of MASH, tirzepatide and semaglutide is approved. So if you see across the spectrum of the fat mass diseases, and also when it comes to just reducing the total body fat weight, you have semaglutide appearing across all these sections along with tirzepatide. Next slide, please. The ADA 2026 obesity pharmacotherapy has also given similar guidelines when it comes to either management of type 2 diabetes or management of obesity in either pre-diabetics, hypertensives, patients with ASCVD, HFpEF, NASH, OSA, or osteoarthritis. In all these cases, we find that there is a demonstrated benefit established by semaglutide and tirzepatide and liraglutide. Next slide, please. So, when it comes to cardiometabolic benefits, we find that in prediabetes, metabolic syndrome, or diabetes prevention, tirzepatide or semaglutide, liraglutide, or orlistat could be used. In type 2 diabetes management, tirzepatide, semaglutide, liraglutide, phentermine topiramate combination can be used. To reduce or remission of MASH, there is tirzepatide and semaglutide. HFpEF management involves semaglutide and tirzepatide. And when it comes to chronic renal failure progression, semaglutide and tirzepatide are recommended. Even for blood pressure lowering, tirzepatide, semaglutide, and a combination of phentermine or topiramate is recommended. And for MACE prevention, semaglutide is recommended. These hierarchies are based on clinical trial data. Drugs are not listed when relevant data are not available. However, weight loss, regardless of treatment modality, may provide the benefit. The results also reflect available data at time of the publication and will need revision further. In osteoarthritis and obstructive sleep apnea, we find mechanical benefits of reduction of weight offered by semaglutide and tirzepatide. Next slide, please. So, when it comes to the pharmacotherapy of type 2 diabetes associated comorbidities, we find that in patients who are having either cardiovascular or renal risk reduction or an achievement and maintenance of weight and glycemic goals, in all of these conditions, we find GLP 1 receptor agonists being recommended as a first line drug. Next slide, please. Let us see into some clinical evidence with semaglutide. Semaglutide and cardiovascular outcomes in patients with overweight and obesity were studied. There was this study to investigate the effect of semaglutide on cardiovascular outcomes in patients with overweight or obesity without diabetes. It was a randomized, double blind, placebo controlled, multicentric, event driven superiority trial. There were 17,604 trial participants. Inclusion criteria was a BMI of 27 or greater, who were 45 years or older, with an established CVD like a prior MI, stroke, or a symptomatic PAD, with no history of diabetes with a HbA1c of less than 6.5%. A mean follow up of about 39.8 months was done. Once weekly subcutaneous semaglutide injections or a placebo were given for approximately 8,800 patients each. The endpoints were cardiovascular death, non fatal MI, or non fatal stroke. It was noted in this study, next slide please, that there was a 20% reduction in the risk of MACE. The primary cardiovascular endpoint, that was death from cardiovascular events, non fatal MI, or non fatal stroke, reduced by 6.5% in semaglutide group and 8% in the placebo group. There was a 15% reduction in risk of death from cardiovascular causes, which was 2.5% in the semaglutide group and 3% in the placebo group. Next slide, please. The secondary endpoints evaluation showed that there was a reduction in the body weight, reduction in the waist circumference, which was also associated with significant HbA1c changes, reduction in the blood pressure. There was also an improvement in the heart rate and also an hsCRP reduction, indicating that inflammatory markers were reduced. There was also a reduction in all the lipid parameters like total cholesterol, LDL, and triglycerides, and also an improvement in the HDL cholesterol. The next study was a STEER study. Semaglutide is associated with a lower risk of cardiovascular events when compared with tirzepatide in patients with overweight or obesity and ASCVD and without diabetes, even in routine clinical practice. The study population over here was people of more than 45 years of age who were either overweight or obese with an established ASCVD but who did not have diabetes, and they were initiated on semaglutide or tirzepatide. The aim was to assess the real world incidence of MACE during treatment with semaglutide or tirzepatide for chronic weight management in routine clinical practice. The primary outcome measures were a revised 3-point MACE involving MI, stroke, and all cause mortality, and a revised 5-point MACE involving MI, stroke, hospitalization for heart failure, coronary revascularization, and all cause mortality. Next slide, please. The study results showed a reduction in the revised 5-point MACE as well as a reduction in the revised 3-point MACE. We also note reduction in individual events of MI, heart failure, stroke, coronary vascularization, as well as in CV related mortality. Next slide, please. This study concluded that there was significantly lower risk of revised 3-point MACE with semaglutide versus tirzepatide. Overweight or obesity and ASCVD, but without diabetes, had a lower risk of CV events with semaglutide compared with tirzepatide. Significantly lower risk of revised 3-point MACE, that is 29% with semaglutide versus tirzepatide, was noted in this study. Next slide, please. We have another case over here. This patient, Mrs. Lobo, is 52-year-old and a homemaker. She has a height of 170 centimeters, weight of 80, and a blood pressure of 140 by 86. She has no history of type 2 diabetes or CVD, but deranged lipid profile. She has a habit of food craving and overeating. Her HbA1c is 6.6%, which is at pre-diabetic levels. Postprandial is also slightly high at 150, BMI of 27.7. But her lipid values are high with an LDL of 110 and triglycerides of 180. Presently, she is on atorvastatin, aspirin, and a combination of telmisartan and amlodipine. She has a poor adherence to diet and exercise due to her cultural meal patterns and her work. Next slide, please. In her case, we find that GLP-1 receptor agonist will be a very good choice. GLP-1 receptor agonists are expressed not only in the pancreas, both in the alpha and the beta cells, but also throughout the cardiovascular system, including the cardiomyocytes, vascular endothelial cells, smooth muscle cells, central nervous system, kidneys, and the lungs. They improve the pancreatic function and hence improve the glycemic control. They cause weight loss, reduction in the adipose tissue, reduction in events of coronary artery disease, stroke, hypertension is reduced, steatohepatitis is reduced, atherogenic lipids are reduced, and reduction in the peripheral vascular diseases. Next slide, please. This is the ideal recommendations by the WHO for the height and weight of patients. If you notice here, the healthy weight is at a BMI of 18.5 to 24.9. Anything at 25 and more is increased overweight, or it further gets classified into obesity of class 1, 2, and more than 40 BMI would be obesity class 3. Next slide, please. And at every 1 kg increase of a BMI, we find there is an increased incidence of aortic valve stenosis, heart failure, deep vein thrombosis, hypertension, peripheral artery disease, coronary artery disease, atrial fibrillation, pulmonary embolism, subarachnoid hemorrhage, abdominal aortic aneurysms, intracerebral hemorrhage, and ischemic strokes. Next slide, please. The ESC Clinical Consensus Statement on Obesity and Cardiovascular Disease has the recommendations for the usage of GLP-1 receptor agonists. Glucose lowering medications with effects on weight loss, like GLP-1 receptor agonists, should be considered in patients with type 2 diabetes with overweight or obesity, is what it says. GLP-1 receptor agonists with proven cardiovascular benefits like liraglutide, semaglutide, dulaglutide, epiglutide are recommended in patients with type 2 diabetes and atherosclerotic CVD to reduce the CV events, independent of the baseline or target HbA1c, and independent of concomitant glucose lowering medication. The GLP-1 receptor agonist semaglutide should be considered in overweight or obese chronic coronary syndrome patients, even without diabetes, to reduce the CV mortality, MI, or stroke. So we find here that it is not just in diabetics, even in non-diabetics, to reduce the body weight and hence reduce the events of cardiovascular events and peripheral vascular events. GLP-1 receptor agonists are recommended. Next slide, please. When it comes to prevention of ASCVD in people with type 2 diabetes, we need to have emphasis on nutrition and lifestyle blood pressure management. And along with all of these things, we find that GLP-1 receptor agonists and SGLT2 inhibitors are highly recommended. Next slide, please. The obesity pharmacotherapy, as stated by the ADA in 2026, says that for preventing progression of type 2 diabetes, there is a demonstrated benefit offered by tirzepatide and semaglutide. For lowering of blood pressure, there is a demonstrated benefit by tirzepatide, semaglutide, and orlistat. When it comes to reducing the heart failure events, demonstrated benefit is shown by semaglutide. Reducing hypertension, there is a demonstrated benefit by tirzepatide. Glucose lowering benefits are demonstrated by tirzepatide, semaglutide, and liraglutide. Reducing MACE events is demonstrated by semaglutide. MASH benefits are demonstrated by semaglutide, and reducing pain as in knee osteoarthritis potential benefit is offered by semaglutide, tirzepatide, and liraglutide. In the case of inadequate treatment response to current obesity medications, consider treatment intensification. You could use an alternate obesity medication or increase the dose of current medication or combine your obesity medication with intensive behavioral therapy and structured lifestyle patterns. Add another obesity medication to the current medication or continue obesity medications and refer for metabolic bariatric surgery. So, bariatric surgery is becoming one of the last options when it comes to management of obesity. Next slide, please. As for the European Association for the Study of Obesity for individuals with obesity, the treatment algorithm states that if there are only body weight management in obesity with no other complications present, you could consider tirzepatide, semaglutide, phentermine, topiramate, liraglutide, naltrexone, bupropion, or orlistat. If there are complications present, semaglutide, tirzepatide become the leading contenders. Uh, I think the slides are not coming.
Uh, yes, just 1 minute, ma'am.
Yeah.
Got power cut. Just
Yeah.
1 minute. We'll share. Ma'am, am I visible, madam?
Yeah, your slides are visible.
Okay, ma'am. You can continue, madam.
Yes, I think we've finished the slide. You could come on to the
Okay, ma'am.
next. Next.
This one.
Yes.
Okay, ma'am.
Yeah. So, the 2024 EAC guidelines for the management of chronic coronary syndrome says that SGLT2 inhibitors are recommended in patients with type 2 diabetes and chronic coronary syndromes to reduce the CV events independent of baseline or target HbA1c and independent of concomitant glucose lowering medications. This is a class 1 evidence. The class 2A evidence says that GLP-1 receptor agonists like semaglutide should be considered in chronic coronary syndromes, even in patients without diabetes but with overweight or obesity, in order to reduce the CV mortality, MI, or stroke events. The only anti obesity drug approved by the EAC guidelines for chronic coronary syndrome without diabetes with overweight or obesity on the basis of the SELECT trial is semaglutide. The SELECT trial, next slide, please. The SELECT trial was done to investigate the effect of semaglutide on cardiovascular outcomes in patients with overweight or obesity without diabetes. It was a randomized, double blind, placebo controlled, multicentric event driven superiority trial involving 17,600 patients. Next slide, please. I think this is a repetition of the slides. Could go to the slides, yeah.
This one, no?
No, the direct cardiovascular mechanisms. Next slide.
This one, just one.
The pleiotropic effects. Yeah, you could be at this slide, yeah. So the pleiotropic effects noted where GLP-1 receptor agonists had anti-atherosclerotic effects, endothelial functions were improved, there was a myocardial protection offered, blood pressure reduction, lipid modification, glycemic control, and weight loss. In view of all of these, it is recommended for cardiovascular, renal benefits, as well as improved metabolic control. Next slide, please. From the leader and sustained trials, it was noted that we need to have a primary preventer. Multi-source AI-driven analysis of CVOTs and electronic health records found that elderly patients without prior cardiovascular events who were receiving a GLP-1 receptor agonist therapy experienced an absolute CV risk reduction comparable to those in secondary prevention. This suggests high-risk primary prevention in patients may derive equivalent benefits. Next slide, please. The score was a primary prevention real world study with an objective of evaluating semaglutide 2.4 mg effectiveness in reducing the risk of cardiovascular events in US adults with ASCVD and overweight or obesity without type 2 diabetes in clinical practice. It involved adults of more than 45 years of age who were overweight or obese with an established ASCVD. Semaglutide of 2.4 mg was given to about 9,321 study participants, and a follow up period was there for about 7 months until the earliest event of end of continuous enrollment, end of data availability, initiation of a non semaglutide GLP-1 or GLP-1 GIP combination, bariatric surgery, or death. The endpoints evaluated were MACE-3s. Next slide. This showed that there was a lower risk of 3-point MACE with semaglutide 2.4 mg. In this real world study of patients in the US with overweight or obesity and ASCVD without type 2 diabetes suggested that semaglutide 2.4 mg was associated with a significantly lower relative risk of MACE-3. So, next slide, please. If we consider a summary of the different guidelines issued in 2023 and 2024, we find that in 2023, ADA has given a strong recommendation of class 1 for GLP-1 receptor agonists with proven CV benefits in type 2 diabetes. The ESC 2023 guidelines for diabetes and CVD gives a class 1 recommendation for GLP-1 receptor agonists in type 2 diabetes with ASCVD. ESC 2024 guidelines for chronic coronary syndrome management also has a new recommendation for semaglutide for overweight or obese patients with CS with or without diabetes. The FDA 2024 March guidelines has approved semaglutide 2.4 mg for a CV risk reduction. AHA-ACC also strongly supports for the use of ASC semaglutide in patients with an established ASCVD with type 2 diabetes. So we find that across different guidelines, GLP-1 receptor agonists are gaining acceptance for the reduction of cardiovascular events. Next slide, please. In summary, we could say that MACE reduction is a class effect of GLP-1 receptor agonists, and a 12 to 27% MACE reduction is seen in high CV risk type 2 diabetics patients, with benefits varying by age and by population. The SELECT trial transformed the field. 2.4 mg of semaglutide reduced MACE by 20% in 17,604 non diabetic patients who had obesity and established CVD, the first proven CV benefit from any obesity medication. Diabetes is not a prerequisite. Following the SELECT trial, CV benefit is now established in patients even without diabetes. The FDA approved semaglutide for CV risk reduction does not require a diagnosis of type 2 diabetes. The benefit is risk dependent but extends beyond secondary prevention. Absolute benefit is greatest in established ASCVD, but high risk primary prevention in patients is also benefiting significantly. Pleiotropic mechanisms are real and significant. GLP-1 receptors exist not only in the heart and the vasculature. Preclinical and clinical data confirm anti-atherosclerotic, endothelial function improving, anti-inflammatory, and direct myocardial effects, which go beyond the glucose lowering or weight lowering effects. The guidelines have also responded, and across different guidelines, we find support for the use of GLP-1 receptor agonists for a CV risk reduction, with the strongest recommendation in established ASCVD with or without diabetes. It should be proactively considered by those in both cardiology and diabetes practice. Thank you for your patient hearing. We're open to any questions.
Thank you, madam. Am I audible, madam?
Yes, Aman, I can hear you.
Thank you. I would like to take a moment to thank you all for your participation in this today's scientific session. Your presence and immense engagement have made this event truly remarkable. Firstly, I would like to extend our heartfelt gratitude to Dr. Aruna Madam. Your insightful presentation and the depth of your expertise have greatly enriched our understanding. Your contributions are invaluable, and we are grateful for the time and effort you have invested in preparing and delivering such a informative session. I would also like to acknowledge and thank all our attendees. Your active participation, question, and discussion have made this session interactive and dynamic. Thank you all once again for making this scientific session a success. We look forward to your continued support and participation in our future event. With this, we officially call off the session. Thank you once again, madam.
Thank you. Thank you for this opportunity. And thanks to all those who have joined. Good evening.
Good evening.
Yes, with your permission, we'll conclude. Hello.
Hello, yes, madam.
Yeah, we can end the meeting.
Okay, madam. Yes.
Okay, thank you.